Good evening, everyone, and thank you, Parminda. Tonight we'll be discussing asthma. I will begin by reviewing the definition of asthma, discuss the prevalence and risk factors for developing asthma, and then I'll give an overview of the clinical management and some insight into the public health response. I think the best way to begin the presentation is to discuss what asthma really is. Asthma is a disease that affects the lungs. It causes repeat episodes of wheezing, breathlessness, chest tightness, and nighttime or early morning coughing. If someone has asthma, he or she has it all the time, but asthma attacks will only occur when some precipitating factor bothers the lungs. We know that if someone in the family of a person has asthma, other family members are more likely to have it too. In most cases, we don't know what causes asthma, and we don't know how to cure it. However, it can always be controlled to a large extent. This drawing from the National Heart, Lung, and Blood Institute compares the normal airway on the left to the airway of a person with asthma on the right. And as you can see, during an asthma episode, the airways become extremely narrow due to muscle constriction, swelling of the inner lining, and mucus production, causing very limited airflow. And during severe episodes, the airways may become extremely narrow, compromising airflow and leading to fatalities. And that's the biggest problem, is when the asthma is uncontrolled and these airways get filled with mucus, the muscles constrict, and the patients have extreme difficulty breathing. What I want to discuss now is asthma prevalence in the United States. Asthma affects a large proportion of the population. This is data from 2010. It affects 25.7 million people, including 7 million children under the age of 18. And so you can see that it's a significant healthcare and economic burden to patients, the families, and the society in general. And in 2010, almost 1.8 million people visited an ED for asthma-related care. And of those, 430,000 were hospitalized because of asthma. This is data showing the asthma prevalence in the United States, and it shows you the asthma prevalence increased from 3.1% in 1980 to about 5% in 1996. And then in 2001, it increased to 7.3% and 8.4% in 2010. So despite our treatment and despite the knowledge we have, the asthma prevalence is increasing. There are many factors which are thought to contribute to it, but you know, my real aim for presenting the slide was to show you that despite what we know about asthma, the prevalence is increasing. 1 in 12 people, that's about 26 million or 8% of the population, had asthma in 2010, compared with 1 in 14 or about 20 million people or 7% in 2001. This is a slide that I'm presenting just to show you the asthma prevalence by race and ethnicity. Blacks are more likely to have asthma than both whites and Hispanics. And then some people are more likely to have asthma than others. And what I would do, in this slide, just focus on the yellow bars. And you can see that current asthma occurs more in children than in adults, and females more than males. And when you come to race and ethnicity, asthma prevalence is higher among Black people, lower among Asian and Hispanic people compared to white people. And then among Hispanics, for some reason, Puerto Ricans were more likely to have asthma compared to individuals that are Mexican. Asthma prevalence increased with decreasing annual household income. And as far as geographic region, current asthma prevalence was higher in the Northeast than in the South or in the West, and it was higher in the Midwest than in the South. And for some unexplained reason, prevalence does not seem to matter between metropolitan and non-metropolitan areas. So patients that are in the city or in rural areas tend to have the same prevalence of asthma. Among children, asthma prevalence was higher among male children aged 0 to 4 years and aged 5 to 14 years compared with female children in the same age group. But asthma prevalence was similar in male and female children aged 15 to 17. So younger children, the males seem to be more affected than the females, but as individuals get older, the prevalence seems to be the same. Both children and adults showed a deep. But this shows this is a slide depicting children and adults with current asthma in the United States from 2001 to 2010. And the interesting fact here is that both children and adults showed a decrease in asthma attacks. In 2001, 61.7% of children and 53.8% of adults with asthma had at least one asthma attack. But in the previous 12 months, compared to 58.3% and 49.1% in 2010. So although the prevalence is increasing, the asthma attacks seem to be decreasing, which is probably a reflection on the treatment that we're providing and the compliance of the patients. Children with asthma were more likely to have at least one asthma attack during the previous 12 months. And asthma attacks occurred more often in females than males, and among those with a family income less than 100% of the federal poverty threshold. And that's probably a reflection of their ability to access the care. There are a number of risk factors for developing asthma. The genetic characteristics, occupational exposures, and environmental exposures. When I talk about genetic characteristics, that really refers to atopy. Atopy is a body's predisposition to develop an antibody, and this antibody is immunoglobulin E. And immunoglobulin E is the predominant immunoglobulin involved in asthma and asthma attacks. It can be measured in the blood, and there are many other diseases that are associated with atopy and this immunoglobulin E. These include allergic rhinitis, hay fever, and eczema. I just gave you a few examples. Now, there's an association with, now when we discuss the association of the various elements, the literature tries to divide that into sufficient evidence of a causal relationship where we know that there definitely is a causal relationship. Then when the evidence is less strong, we classify that as some sufficient evidence of an association. And then slowly the evidence starts to dissipate. You have limited or suggested evidence of an association, and inadequate or insufficient evidence to determine an association. And then the very last one is where there's very limited or suggestive evidence of no association. And I just want to give you examples of this. I've separated them they've been separated into biologic agents and chemical agents. Now there's the house dust mite. There's sufficient evidence of a definite causal relationship. Where there's limited or suggestive evidence of an association includes cockroaches and then respiratory syncytial virus. And then where the chemical agents, the only one that's found to be of sufficient evidence to suggest a possible association is environmental tobacco smoke. Now remember, this is asthma development. So this is where patients who don't have asthma can develop asthma if they're exposed to either house dust mite and possibly cockroaches, respiratory syncytial virus, or tobacco smoke. Those are the individuals that will develop asthma. But now we come to where patients already have asthma and where they may develop an exacerbation of their asthma due to certain factors. And the fact that there are a number of factors here which are much where the evidence is much more to suggest that these will cause an exacerbation of asthma, not necessarily causing the asthma to develop in the first place. And examples of these are exposure to cats, cockroaches, and house dust mite. There's sufficient evidence of an association with dogs, fungus or mold, and rhinovirus. There's limited evidence to suggest domestic birds, chlamydia, mycoplasma pneumonia, and RSV. And then there is evidence to suggest environmental tobacco smoke also causes an exacerbation of asthma. But there's very often I'll come with patients who will say they're exposed to certain perfumes or fragrances that tend to exacerbate the asthma. Although I have seen it in certain patients, in the literature, there's limited evidence to suggest that there's a strong association with this. Reducing exposure to house dust mite is important. And the ways of doing this is by using bedding encasements, washing the bed linens weekly, avoiding down fillings, limiting stuffed animals to those that can be washed, and then trying to limit the humidity level. And reducing humidity is associated with an exacerbation of asthma. So dehumidifiers can be very useful in helping to reduce the humidity level and decreasing the exacerbation episodes. Reducing exposure to environmental tobacco smoke is very important. It's important both in the development of asthma and the exacerbation of asthma. It's very important with school-aged children and adults. There's an association between environmental tobacco smoke and asthma development among preschool-aged children as well. Reducing exposure to cockroaches is also important. Here I've just given you some examples of the oriental cockroach, the brown banded cockroach, and the American cockroach. But the real aim of this is to remove as many water and food sources as possible, keeping the house clean at night, not leaving food lying around, making sure all spillages are cleaned, and there's no availability for the cockroaches to either come into the house, and then when they do come into the house, to sorry, just have a slide here. And when they do come into the house, to grow and perpetuate in the house. People that are allergic to pets should not have them in the house, but it's very difficult in certain situations, obviously. And so what we recommend at a minimum is when patients are sleeping, if they do have pets in the house that they're allergic to, they should not allow the pets in the bedroom. Mold is also important. Eliminating mold and the moist conditions that permit mold growth may help prevent asthma exacerbations. This is very important as well. Now, I'm sure you know these, but I'm going to mention them. Other asthma triggers are air pollution, trees, grass, and weed pollen. And our objective is you can't obviously avoid many of this, but the treatments that we have can control the symptoms and prevent exacerbations when exposed to these triggers. Now, what I want to talk about is the clinical management of asthma. There was an expert panel commissioned by the National Asthma Education and Prevention Program, which is called the NAEPP, and it was developed in 2007. The National Heart, Lung and Blood Institute of the National Institute of Health helped to coordinate this effort. And the treatment recommendations are based on the severity, the control, and the responsiveness. And I'll go through this in more detail. But there are a number of components of asthma care. And the guideline implementation of panel report presents recommendations and strategies for overcoming barriers to the acceptance and use of the updated guidelines. At the heart of the report are 6 key messages to address the issue. And let me come to that now. These are the 6 key messages. This is very important. Inhaled corticosteroids are the most effective medications for long-term management of persistent asthma, and they should be used by patients and clinicians as recommended in the guidelines for controlling asthma. An asthma action plan. All people who have asthma should have a written asthma action plan to guide their management efforts. It's very important. The third one is asthma severity. All patients should have an initial severity assessment based on the measures of the current impairment and future risk to determine the type and level of initial therapy needed. Then when we get to asthma control, this really involves when patients come for their planned follow-up visits. Asthma patients should review the level of control with their healthcare provider on the basis of multiple measures of current impairment and future risk. This review can guide clinical decisions and either to maintain the current therapy or adjust the therapy. When we talk about follow-up visits, patients who have asthma should have scheduled planned follow-up visits at periodic intervals to assess their asthma control and to modify the treatment if needed. And then the last one is allergen and irritant exposure control. Clinicians should review each patient's sensitivity to allergens and irritants and provide like a multi-pronged strategy to reduce exposure that make the patient's asthma worse. Sometimes this is more difficult to do, but the first 5 can be done and should be done. I wanted to just review asthma and the diagnosis of asthma. Sure, you're aware, but asthma presents most of the time with coughing, wheezing, shortness of breath, and chest tightness. And very often the patients have a pattern of symptoms that it occurs when they're exposed to going outside, or they're exposed to certain pollens or grass or some other irritant or in the house. And then very often, like I said initially, there's very often a family history of asthma. Atopy exists in families, and in patients, one family member's got hay fever, one family member may have eczema, and then you have another family member who has asthma. These are probably the most important symptoms. A troublesome cough, particularly at night, that awakens the patient, is a very important symptom. And one of the categories of asthma is called cough variant asthma, where patients don't necessarily have to have wheezing, they don't necessarily have to have chest tightness. They can present with a troublesome cough. It's a dry, non-productive cough that occurs either at night or it occurs during the day, and it can be very irritating, and it can be very intractable. But then we have the patients that present with a normal, the normal symptoms that we associate with asthma, such as coughing or wheezing after physical activity, breathing problems during particular seasons, coughing, wheezing, or chest tightness after exposure to allergens such as pollen, grass, dust, or colds that last more than 10 days. And then a very important factor is then that very often patients will tell us that they've used an albuterol inhaler now and then prescribed by somebody, and it relieves their symptoms. Then they don't use the albuterol for a period of time, and then they get recurrent symptoms. What we look for when we diagnose asthma is we look for wheezing when we examine a patient, and we listen to the chest or the stethoscope and listen for wheezing. But this can be very difficult because very often patients come to us with symptoms, or I see patients with symptoms, and they don't have the actual signs when I examine them. Hyperexpansion of the thorax means that when you examine the patient, the lungs are expanded more than they should be. And the reason for that is the patients have difficulty breathing. And because they have difficulty breathing, they retain air in the chest, and the lungs get hyperexpanded. And then these ones, like, they have increased nasal secretions or nasal polyps. And then the associated findings, and it's always important to look for this, like atopic dermatitis, eczema, or any other allergic skin reactions, which may suggest that the patient has asthma. Now, the way we diagnose asthma, one of the ways of diagnosing asthma, is when the patients come to the office or for a visit, we do what's called a pulmonary function test. And what we do is we actually look at the function of the lung. We look at if there's any obstruction to airflow in the lung. We look at how large the lungs are, how big the lungs are, and then we look at the oxygen diffusing in and out of the lungs. So it's a very useful test. But, I've had many patients where the spirometry or the pulmonary function testing is normal, and then we have to go on to do other investigations to try and determine whether they have asthma. One of those tests is called the methacholine challenge test, where you give the patients a certain medication that actually causes the airways to constrict. And in a normal person, the airways wouldn't constrict all that much. But in a patient with asthma, we get significant constriction. So, depending on the patient, we would do the specific tests in order to make the diagnosis. Very often we have patients coming in who do the pulmonary function testing, and you can see immediately they've got airway obstruction, and then the diagnosis is easy, and the treatment is very much more simplified. Now, the medications to treat asthma come in several forms, but I wanted to try and simplify it and just mention that there are two basic categories. There's the long-term control of asthma and quick relief. That means the patient that's got asthma is on medications that he takes on a regular basis every single day, no matter whether he has an exacerbation or not. And then you have these medications which are used for quick relief when the patient has an asthma exacerbation and needs to use something to relieve the symptoms. It's very, very important to note that the long-term control, the medications that are used for long-term control, need to be taken every single day on a regular basis, and they should never, ever be used if the patients have an asthma exacerbation more frequently, meaning that they should not be used more frequently. If you're on the Symbicort, you're on Advair, and you're using that once or twice a day, that's what you stick to. You don't use these medications more frequently if you have an acute asthma exacerbation, because it can be very dangerous. The long-term medications I've mentioned, they're taken daily over a longer period of time, and the medications are really used to reduce inflammation. The corticosteroids are used to reduce inflammation, and the bronchodilators are used to relax the airway muscles and improve the symptoms. And I've just listed the three basic categories here: inhaled corticosteroids and the long-acting beta agonists. Very often we combine them into one medication, such as Advair or Symbicort, which both of these medications contain a steroid and they contain a long-acting bronchodilator or a beta agonist. Beta agonist refers to the mechanism of action, but all it does is you need to know is that a beta agonist or a bronchodilator are really the same medications. And then the leukotriene modifiers, these are medications like Singulair, Montelukast, which are also used. In my experience, the inhaled corticosteroids and the long-acting beta agonists are the most important. The leukotriene modifiers can help, but they're certainly not the cornerstone of the treatment. Now, this is, like I said, the medications used to treat asthma for quick relief are used in acute episodes, and they're generally very short-acting. These medications are generally albuterol, Ventolin, ProAir. Those are used for quick relief to help patients that are having acute exacerbations, but they are not used for long-term control. I won't go through this now, but I just want to mention that it's very important how to use the inhaler. It's very important that when you go to a healthcare provider, they should take the time, or somebody should take the time to show you or show the patient how to use the inhaler and make sure the inhaler technique is adequate. I can't tell you how many patients I've had that tell me they've tried Symbicort, they've tried Advair, they've tried Ventolin, none of the medications are working. But when you go back, you find that they're not using these inhalers correctly. I want to mention something else, and I'll tell you in the next slide. Spacers can be very useful because some patients do have difficulty, although they try their best to use the inhalers, they can't coordinate the movements or the maneuvers. And spacers can help the patients who have difficulty with inhaler use and can reduce the potential for adverse effects from the medications. So it's the spacers can really help. When I'm talking about adverse effects of the medications, the ones I'm really talking about are, number one, these inhalers can cause hoarseness. They can affect the vocal cords and deposit on the vocal cords, and they can cause thrush. Thrush in the mouth is easy to treat with nystatin or one of the other medications, but often we have patients who are using the inhalers and they have a hoarse voice, and then we have to get the ENT to go down and do indirect laryngoscopy and have a look and see, and then we find out that they've actually developed fungal infection on the vocal cords. So we have to be a little bit wary of this. I must also mention that because you're using an inhaler and you're using a corticosteroid inhaler and you develop hoarseness, I never assume that the inhaler is predominantly the cause of the hoarseness. If the hoarseness persists for a long time, patients need to see an ENT and make sure there's nothing on the vocal cords that's causing the hoarseness, such as polyps or malignancies or something else that can be causing the problem. Don't just assume that it's the inhaler, your asthma is controlled, so you're just going to leave it. I don't ever do that. Now, I do want to mention about nebulizers. Nebulizers are machines that produce a mist of the medication. So you put the medication into the nebulizer, it comes out as a mist. And often I use it for patients that have difficulty coordinating the use of the inhalers or the spacers, or for small children who can't coordinate the use of the devices. And then very often they're useful in patients that have severe asthma episodes, where patients are really distressed. They have difficulty using the spacer, they have difficulty using the inhaler. But if you put the medication into the nebulizer, all they have to do is put the nebulizing mouthpiece in their mouth and breathe in and out. And it's much easier to use. But if patients are able to use an inhaler with a spacer, there's no evidence that using a nebulizer is better. If an individual is able to use an inhaler or a spacer, there's no evidence that using a nebulizer will actually be more effective. The management of asthma includes a number of goals. Number one, to achieve and maintain control of the symptoms. This is crucial. It's absolutely crucial, because the patients that get into trouble are the ones that don't maintain their asthma well. They continue to have symptoms, and then they get exposed to an allergen or something that precipitates an acute asthma attack, which can have catastrophic consequences. Patients that are treated, my goal is to always make sure that they can maintain normal daily activity. It's not acceptable for a patient with asthma to say, I've got asthma, I understand I've got asthma, so I can't exercise, I can't do my normal daily activities. It's debilitating, and that's the way I am. It's just not acceptable. The individual needs to be at a point where the person can maintain normal daily activities. And that includes, making sure that the patient's on adequate therapy, but also making sure that the person is using it and compliant with the treatment. And then in my patients, I like to do a pulmonary function test if the patients are stable at least once a year. I like to make sure that the pulmonary function testing is done to make sure that the lung function is close to normal as possible. And very often you can see patients that have asthma and they're not symptomatic, but when I do the pulmonary function testing, I can see that in the very, very small airways of the lung, they still have obstruction. And that suggests to me that although the patient feels that they're doing well, it suggests to me that, there is a possibility that I can adjust the medication and get the lung function closer to normal as possible. It's very important to prevent asthma exacerbations. And that really comes from, maintaining good treatment, making sure they're on good treatment and making sure the patient is compliant with the treatment. Like I said, avoiding adverse effects from the asthma medications. I mentioned the adverse effects are the thrush in the mouth and the hoarseness, but there are other adverse effects that can happen. And one of the ones that you need to keep in mind is that although you see most of the when patients are on oral steroids, they get problems with hyperglycemia, with high glucose levels and fractured bones. But these inhalers can, on the rare occasion, cause osteoporosis. So all my patients, whether they're female or male, I do try and tell them as they get older to make sure they have bone density scans done on a regular basis, just to make sure that they're not developing osteoporosis. And then obviously the management goal, obviously the big one, is to prevent asthma mortality. And asthma symptoms can creep on slowly. They can creep on, creep up very insidiously. And then the patients land in a really, really bad situation just because they were inadequately controlled. So the asthma action plan needs to be developed with a physician. It always needs to be tailored to the individual needs. And then we have to educate the patients and family about all aspects of the plan. And this includes recognizing the symptoms, knowing when you're wheezing, are you getting chest tightness? When you're exposed to certain allergens, do you develop symptoms? The patients need to know that. And when they do know that, sometimes they're able to avoid it and recognize the symptoms and avoid the asthma exacerbation. And then, like I've said before, the medications have significant benefits, but they also have a number of side effects which need to be kept in mind. And then proper use of the inhaler and monitoring that peak expiratory flow. This is just a summary of the instructions for self-management of asthma. The plan contains places in which the doctor can fill in directions for the medication, the peak flow numbers, the asthma triggers, and then the actions to take in the case of an asthma attack or an emergency. And this written asthma action plans, it really specifies details for the patient's daily management. And you can see here they've got it's got red, which is a real problem, yellow, which is trying to be cautious, and green is when you're in a good situation. Peak flow meters are important because they allow the patient to assess the status of his or her asthma. And patients need to use the peak flow meters frequently. And no matter the severity, patients should always monitor their peak flows. Normal peak flow is about 400 to 700 liters per minute. But we have individual patients that can't get there. They can't get there. But as long as I know my patients at a certain baseline, I'll know when they drop precipitously that there's a problem. So you don't have to be within normal range, but I want the patient to be at least within their baseline. And they do that by monitoring the peak flows on a regular basis. So people with moderate or severe asthma should take their readings every morning, every evening. After an exacerbation is very important because that shows me that the patient's getting back to where they should be after an exacerbation. And then before inhaling certain medications, this is really useful because if the patients are placed on Advair or they're placed on Symbicort or they're placed on another bronchodilator, it gives me an idea that, well, they were doing 300 before they started the medication, and it increased to 400. So at least I know that I've seen a response to the medication. I wanted to talk about managing asthma and the indications of a severe attack. It's very important to recognize this because, like I said, the symptoms of asthma can creep up very insidiously, and the patients can land in a very, very bad situation without really knowing what to look for. When patients are breathless and when they're breathless at rest, meaning they're not exercising, they're not walking, they're not doing anything, and they're just very breathless at rest. When patients are hunched forward means they're trying to get more and more air into the lungs, and they're trying their best to do it, but they're unable to do it. And then speaking in words rather than complete sentences. If individuals are speaking in words and they can't complete sentences, it means that they've got airway obstruction to such a degree that it's not allowing them to speak properly. Agitation is very important because when the mental status changes of a patient with asthma, it can be a real emergency. And the reason for that is that when patients have an asthma attack, they breathe very fast. And the carbon dioxide in the blood is pushed out through the lungs because they're breathing so fast. But as the asthma attack gets worse, the airways start to close down. And when the airway closes down, the carbon dioxide in the blood increases because they cannot get it out of the lungs because the airways are constricted. And because they cannot get it out of the lungs, the carbon dioxide in the blood continues to rise. And when the carbon dioxide rises, that causes the mental status changes and the agitation. So this is a very, very important sign that the asthma is getting to the point where the patient needs to, be in hospital and managed in hospital. And then the peak flow rate less than 60% of normal is an indication of a severe attack. So individuals can do a number of things to manage the asthma. Like I said, having an individual management plan containing the medications the patient's on, and this includes the controller. That means the long-term medications like the Symbicort or the Advair or some of the medications that they're using long-term. And then what medications they're using for quick relief. If a patient that goes out and exposed to grass or pollen or trees or something, they need something to be able to give quick relief if they need it. They have to identify the asthma triggers, and then they have to have an idea of what to do when they're having an asthma attack. You have to have a plan. Patients have to have a plan of what to do during an attack. And then educate yourself and others. Educating others is important. Family members can intervene and act if things get out of hand and they realize that the patient's having a very severe asthma attack. So this includes asthma action plans and environmental interventions. And then I just mentioned too at the end, seeking help from asthma resources and joining an asthma support group. I just wanted to briefly mention the public health response to asthma and some of the environmental interventions. This really helps people create and maintain a healthy home, school, and work environment. And it's really, it's what we do as individuals really extends to what we can do as a public health response. This includes assessment to identify the asthma triggers, education on how to remove asthma triggers, and then remediation to remove asthma triggers. There's 6 strategies for addressing asthma with a coordinated school health program. And I mentioned this because it's so important at school to be able to, help the children that have asthma and make sure that they're adequately treated. And this includes management and support systems, health and mental health services. This is very important because very often children with asthma are ostracized at school. They can't breathe. They don't know the reason for their problem, and they're ostracized by the other children. Asthma education for students, staff, and parents, having a healthy school environment. Physical education and activity is very important. And that goes really back to what I was saying before. There should be no reason whatsoever that a child with asthma cannot exercise and do what every other child is doing. There should never be a situation where the child is compromised because he's on inadequate therapy. And then school, family, and community efforts. So really the key aspects are it requires a coordinated team, including all these aspects: the mental, the physical health education, the environment, the family, and community efforts. I wanted to mention here that Asthma is a leading chronic disease, and that causes a significant amount of school absences. It's a common disease that's addressed by school nurses, and it affects everyone, including the teachers, the administrators, the nurses, the coaches. So it's a significant problem in the schools. And just to give you an idea, if you have 30 children in a classroom, 3 of those children are going to have asthma. So, I think according to the National Health Interview Survey that was done in 2004, parents reported that about 9.6% of their school-aged children had been told by a doctor that they have asthma. So it can be a real problem, and it needs to be recognized. And then I want to mention about poor air quality. This can include fumes and vapors and the presence of tobacco smoke. So I think I'll end the presentation now. In summary, asthma is a leading cause of limitation in daily living. It's a significant public health problem. And in this presentation, I've reviewed the definition of asthma. I've discussed the asthma prevalence and risk factors for developing asthma. And I've tried to give like an overview of the clinical management and some insights into the public health response. I hope the presentation was beneficial, and I've tried to leave some time for any questions which anyone may have.
Thank you so much, Dr. Levy. We do have several questions that came through, so I'm going to start by going down these questions. So the first one is, if you don't have asthma symptoms, is it still important to take your medications?
It's absolutely important to take the medications, and that's the reason for the medications. Because when you do not take the medications, that's when the symptoms will reoccur and become prevalent. The issue with that is that I must say I do have some patients where they've been stable for a number of years and they are on medications. And in that situation where I think that the asthma may be getting better, or maybe there's a situation where they don't need the medication, then I slowly decrease the medication. If they were high dose corticosteroids or they were on a high dose of whatever bronchodilators, I slowly decrease it in order to see if they would get an exacerbation of their symptoms when we decrease the medicine. But I would do that with under the care of a physician. You need to make sure that's under care of a physician. If you're not having symptoms, it probably means that the physician or the individual that's treating you is doing a good job, and you're able to do your normal daily activities, and the asthma is well controlled.
Great, thank you so much. So here's another question. Does exposure to pets at a young age help prevent asthma or precipitate asthma?
The literature that I've read is that exposure to pets can precipitate asthma. It can actually precipitate asthma.
Great. Next question. Is there any way to determine if you were born with asthma?
That's a difficult question, because the smooth muscle in the airway normally develops at age 1 year. So it's very unusual for children less than 1 year to develop asthma. So when you say born with asthma, you're not born really with asthma. You're born with a predisposition to develop asthma. And that's an atopy that I mentioned in the beginning of the talk. You've got some atopy, or you've got some IgE or eosinophils that will actually, if you're exposed to an allergen, you'll develop the asthma. So it's not really being born with a predisposition to develop asthma. You're not born with asthma, you're born with a predisposition to develop it.
Great, thank you so much. How likely is it that inhaled corticosteroids will affect bone health?
They can affect bone health, and it's not very prevalent, but it can do it. And oral corticosteroids and inhaled corticosteroids can both do it. That's why I tell patients, as they get older, they should have their bone density checked, because it's pretty unusual. I must say, I don't have a lot of patients that's happened to, but I'm going from what it says in the literature, and the literature says that patients with inhaled corticosteroids can develop osteoporosis and bone fractures. So that's why I just make sure, as individuals age, they should have bone density checks done anyway. So that's what I recommend, just to keep an eye on it, not to be overly concerned about it, but just to be aware of it.
Thank you. Regarding treatment options for environmental allergies, what are your thoughts about long-term use of daily or oral antihistamines and inhalers?
I don't like to use antihistamines on a regular basis. I don't, if an individual it's not really, using an antihistamine is not really going to control the environmental issue at all. It's not going to do that. And taking corticosteroids or taking medications to control the environment is not the way to do it. What you need to do is if the patient has asthma, they need to be on medications that control the asthma despite the environmental issues. I mean, obviously you're trying to avoid it. If you know something causes the asthma, or you know something is going to be a problem, you avoid it. But just take the therapy needs to be tailored around the asthma itself. It's not appropriate just to say, well, I'm allergic to grass or pollen or outside, I'm just going to take my inhaled steroid every single day, and no matter where I am. It has to be tailored towards the asthma itself, and and it has to be tailored to the individual patient rather than the environmental exposure. And I do not recommend antihistamines for asthma on a regular basis unless there's another reason for using the antihistamine. And some patients do have diseases where they have to use that, but certainly not for asthma.
Okay, thank you. And then the same person also was asking what your thoughts are on the use of montelukast in children for high-pitched coughing.
It's not my real expertise in children, so I'd need to defer that to the pediatricians. I don't know the answer to that with regards to children, but I do know that I do use it in adults with asthma. If I have patients that are on an inhaled corticosteroid like Singulair or Advair, they're using Spiriva or they're using one of the anticholinergics and they're still having symptoms, then sometimes I do try montelukast or Singulair. But my experience with these medications is that they're not. I don't find them to be that useful. I find the mainstay of therapy are is the Advair, the Symbicort medications like that. But now let me mention something else. There are other medications which I didn't refer to in the talk, but I'll mention them now. If patients are not controlled using medications like Symbicort and Spiriva and all those medications, there are medications that you can use which directly interact with the IgE, which is the immunoglobulin E level in the blood. And a medication like that is called Xolair. I'm sure maybe some people have heard of it. That's one of the medications that can be used. And then when you're talking about the interleukins, remember the montelukast and those medications do affect the interleukins, but there's a specific medication that affects interleukin 5, which is against interleukin 5, which is called Nucala. It's Nucala, and that affects interleukin 5, which decreases affects the eosinophils, and it prevents the eosinophils causing the asthma. So if I have a situation with a patient who's uncontrolled, I may try, if they're getting to a point where they're really uncontrolled, before I try montelukast or one of Singulair, I would go for, these medications like Xolair or Nucala.
Great, thank you so much. What do you think of the new injection asthma medications? There's one here that's written Dupixent, I guess.
Yes.
And she thinks there's two others.
They are very useful medications. They need to be done obviously with a interaction with a pulmonologist, but they are very, very useful new medications that are very useful and good. And these are medications that we never had available years ago. You know, we had the inhaled steroids and we had the Ventolin, but we never had any of these, and they can be very useful in certain situations. And you know, the situations I'm talking about are where when we start these medications, we would check the patient's IgE level, we would check the patient's eosinophil count, we would check certain blood values, and then decide based on these what medication the patient would be best suited for. So they can be very useful, and they can be very, very important, because patients that have severe asthma that don't respond to the corticosteroids like Advair, Spiriva, Symbicort, those medications, it can be an absolute catastrophe if they're exposed to an allergen and they're poorly controlled. So these medications can be life-saving, and they can be very useful.
Excellent, thank you. Okay, so this is an interesting question. One of my asthma triggers is cold air. A family member with temperature issues has recently been keeping the AC at 57 to 60 degrees, which triggers my asthma. I got chest pains and tightness. Using a heater in my room has helped this symptom, but is there anything else that can be done?
Well, you know, the environmental triggers, the person's probably done as much as possible.
Right.
But if the person's got you know, asthma triggered by cold air, I would make sure that the person's on adequate long-term maintenance therapy, because if the patient's asthma is triggered by cold air, it's probably going to be triggered by something else. So what I would do is I'd make sure that the long-term medications are adequate, and then I would do pulmonary function testing to make sure that the patient's baseline pulmonary function is at normal level.
Great,
And
thank you.
if it's inadequate, then the medication needs to be changed. But you know, once it's triggered by cold air, I mean, it sounds like the person's done the very best they can, and then you need to go into other treatments.
Okay, thank you so much. Can asthma get in the way of diagnosing Hodgkin's lymphoma?
I have to think about that. No,
Okay.
there should be no reason. There should be no reason. Hodgkin's lymphoma is a lymphoma, which is a cancer, and there should be no reason that the patient with asthma should be compromised in diagnosing Hodgkin's lymphoma, because Hodgkin's lymphoma is diagnosed in two ways. It's either diagnosed by doing a lymph node biopsy, or it's diagnosed by doing a bone marrow biopsy. Or if there's masses or something anywhere in the body, they would do biopsies of it. So there should be no reason whatsoever that it should impede the diagnosis of Hodgkin's lymphoma whatsoever. Definitely not.
Great, thank you. Can anything be done in addition to daily maintenance inhaled corticosteroid and rescue inhaler to mitigate air quality triggers?
Yeah, the one that I know about is to put a dehumidifier in the room, because dehumidifiers, for some reason, when it's very humid conditions, that precipitates asthma. So a dehumidifier in a room, when it lowers the humidification level, generally helps with the asthma treatment. But if this person has got recurrent symptoms and is having problems, I don't focus on the humidification or the dehumidification. My priority is to make sure they're on proper medications to treat it. Doing that with the environmental, adjustment is good. But if you're on an inhaled corticosteroid, an inhaled bronchodilator, and you're still having problems, then you need to be on one of these other medications, including the Xolair, Nucala, or Dupixent, one of the others.
Okay, and then I think this is probably our last question. Any thoughts on HEPA air cleaners or recommendations?
I think they can be very useful. And I've had many patients that have done that, and they have told me that they've used it at night, and it has helped a lot. And I think it can mitigate some of the environmental exposure, and it does help, but it does not in any manner, preclude making sure that the patient's on adequate treatment. That's the mainstay of therapy. I'm always reluctant to advise patients, I do advise them on controlling some of the environmental exposures, but I'm very reluctant to place everything in that area. My biggest priority is to make sure that they're on the adequate treatment. And the treatment is, the mainstay of treatment is the inhaled corticosteroids. That's the mainstay of therapy, and it's taken every day.
Great. Thank you so much, Dr. Levy. Your presentation was awesome, and I'm getting lots